So right now we're going straight to the basic life support segment or session. This is going to be a very practical session as well. So please, let's all get prepared to be a part of this and to participate when we are called upon. So to handle that, I'll invite the MD of Cardio Care Hospitals, Dr. Olalekan.
Good afternoon, everybody. I think this is actually the best time to do BLS because we've just finished taking our lunch. So the energy is still there. Mr. Eno, we need the slide. So that we'll do a small talk. It is supposed to be a practical session. And I don't know if you have our mannequin ready so that we'll just do a small talk and we'll do hands-on and we're able to break into different groups. And I think other people participating are here, Dr. Inua, Dr. Ene, Dr. Idoko, and other members of the team. So we are talking about BLS, and tomorrow we'll be doing ACLS. So today we're starting with the basic life support, and the aim, like I said, is to have a hands-on and know what to do when someone, whether in the hospital, outside the hospital, around you, are developed a cardiac arrest, either a cardiac arrest or a respiratory arrest. And like I said, it's not going to be much of talk. So, but just to show us some basic thing before we start. And that as you try to improve our skill of BLS, each 10% improvement in skill gives us at least 30% chance of bringing back a patient or an individual with cardiac arrest or a respiratory arrest. And the key points of BLS, basic life support, is to be able to do a good chest compression with minimal interruption as much as possible. If it is only chest compression that we can do successfully, we will so doing a chest compression alone effectively, and if you don't have an ambu bag, you don't have anybody to do that, but if you can start compression as early as possible, the chance of bringing the patient back or the chance of return of spontaneous circulation is very high. And so, like I said, includes chest compression, ventilation, and the use of an external defibrillator. Please, do I have one here? External defibrillator. So that is what makes the components of BLS. So you want to provide the patient having a respiratory arrest, cardiac arrest, that opportunity, those skills that involves bringing the heart back, cardiopulmonary resuscitation, use of defibrillator, and at least making sure that the patient can get a fresh breath. So we talk about respiratory arrest. This is a patient that has a pulse, but is not breathing. You are able to feel a pulse. So for this patient, the only thing you need to do is to ventilate, because the patient has a pulse, their cardiac activity is there. So what you need mainly for that patient is ventilation, to do 1 in every 6 seconds. That is 10 in a minute. But for a patient that has no pulse, or the patient is gasping, or you are not sure, because like I said, the aim of this is to start your chest compression as fast as possible. So we don't want you to spend a long time trying to search for the pulse. So if you touch the neck, if you feel the carotid and you're not feeling or you're not sure, assume the patient has a cardiac arrest and start your chest compression. Doing a chest compression for a patient with pulse will not kill the patient. It will not harm the patient. So it's better to err on the side of caution that you are not sure and you start your chest compression. So like I said, doing a chest compression for a patient with pulse will not kill the patient. Once the patient is alive, the patient will kick your hand off and you will know that the patient is actually alive. So, and we've just tried to break the thing down into very simple step so that we don't want us to, it's not about cramming, it's just to be able to understand what to do. And this is what is called the chain of survivor. These are series of events that if you do them promptly and very well, the chance of return of spontaneous circulation is very high. So if you are in the hospital, the first thing you need to do is to be able to recognize a patient that may need resuscitation as soon as possible. So you have 5 patients on admission, a patient with respiratory distress, a patient with shock, a patient with pneumonia, a patient with gastroenteritis. You will know that that patient with severe respiratory distress will likely, in case, if you look at them in the order of severity, that patient may likely be the one that may need resuscitation. So you are watching the patient very well. Everybody is paying extra attention and you are trying to do everything to prevent that and at the same time getting ready in case there is a call. So activation emergency response, high quality CPR, which we will talk about shortly, defibrillation, then the other advanced care. Then for acts of hospital, the first thing is emergency, activation of the emergency area response. In this, our environment, your emergency response is to shout and call for help. Because I don't think there's any 999, 111, 100 is to shout for help. That is activating the emergency response outside the hospital in this environment. Because you cannot single-handedly do a BLS for a patient. So it is fruitless starting chest compression for an individual with cardiac arrest alone, because you will be tired and you will not. So the first thing, if you are alone, is to call for help and alert people so that you have many hands as possible to do that. If you start, you will be tired and you will not achieve anything. So, like I said, we just made it very simple. If you look at the WHO, there are the full table where everything is written. But we just broke it down. It's virtually the same thing. That just, if you can remember 4 C's, and we'll just fill in the gap. Outside the hospital, you find someone unconscious, no pulse, not breathing. Before you start doing macho or Superman, make sure the environment is safe so that you yourself, you will not become a victim and you also will need a CPR. So safety is the first thing. Check that you are safe and the victim is safe. You may need to move the patient out of danger, maybe in the middle of the road or whatever. Part of being safe is patient relative already fighting. We are waiting for you. If it's not safe to resuscitate your patient in the whatever, even in the hospital, make sure you are safe before you start doing that. So you may need to move your patient to a safe place. In the hospital, if you are using a spring bed, you may need to move the patient to a flat hard surface. So you may need to move the patient off the bed on the floor so that you will have a hard surface to do your compression that will serve as a hard surface for your CPR, for your chest compression. So, and all these things are happening simultaneously because, like I said, time is not on your side. So, as you are checking for safety, the next thing you are doing is you are checking for responsiveness. So, you want to call the patient. If it's someone you know the name, you tap the shoulder and call out, "Hello, Mr. Man, how are you?" If you know the name, you can call the name. And as you are calling and response, you are checking. You are calling, checking for responsiveness, and you are checking for pulse using your carotid. As you are checking for pulse, you are also looking at the chest of the patient and also trying to feel with the side of your face, looking at the chest, whether the chest is moving, to see whether the patient is breathing, or feel the air coming from the nostril with the side of the face, and you are checking for the pulse. And you want to do all this within 10 seconds. And that's why I said, if you are not sure that the pulse is there, don't waste time. Just assume the pulse is not there, and you quickly start your CPR. So I said, check for safety, check for responsiveness, and call for help. You cannot do it alone. Call for help, call for more people, call for people to bring, for someone to bring an AED, and also tell someone to, if there is opportunity for advanced life support, to also call for that, so that as you're doing your basic life support, advanced team, they are also on the way. More people are coming to join you for chest compression. Somebody is bringing an AED, and also someone is trying to get an ambu bag and come and assist you with the ventilation. And so immediately what you do next is to start your chest compression. And for your chest compression, what we need to do is using your dominant hand, and you interlock it with the other one like this. So straighten it and put it on the lower part of the sternum, the line across the nipple, and you place your hand. You want your hand to be straight, your elbow not bent, straight, and you want the pressure to come from your shoulder. And you want to press hard and fast. Depth of about 5 cm, and you want to achieve the rate of between 100 to 120 in a minute. So it must not be too slow, it must not be too fast, and you have to allow recoil of the chest in between compression, so that you are replicating the movement of the heart, contraction, relaxation. So it is not something like this. So because this, you are just pressing, you are not allowing the heart to be filled again with blood. So you can count 1, 2, 3, 4. You can see the pressure is coming from the shoulder, and you are allowing the recoil of the chest to come back, and you press to the depth of about 5 cm.
Okay, so I want you to just point out a few things. You can see that his shoulder, the front of his shoulder, is straight with the chest. So if you take a line from this center of the chest, it goes straight to this shoulder. He cannot do, lean back a bit. If you do CPR like this and it's going at an angle, then you are not going to be pushing enough force. And you are going to have to be pushing with your hand, doing like this. Number 2, you can see the elbows are locked, so that it is from the shoulder, the elbow is not bending. It is only from here that the movement is happening. So you should take note of that. Number 3, you can take note of the depth that he's going into. 5 centimeters. 5 centimeters. For a child, 2.5 centimeters. But you can see that, and it is continuous. 1, 2, 3, 4, 5, 6. But enough time to allow the chest recoil. If you do less than, the chances of the CPR being successful depends very strongly on the quality of the chest compression. You can rest so that you know. Depends on the quality of the chest compressions. Okay. Just a recap before we go too far. If you want to start chest compressions, this is why spring hospital beds are not meant to be in the hospital environment. You are not supposed to have spring beds in your hospitals anymore. Tell your CMD that you came to ACS, if they don't sack you. But so now, if you don't have that, every hospital should have a crash cart. It typically costs around 400,000, 500,000, which is a mobile cupboard with everything. If you cannot get a crash cart, call your local carpenter. Hit a cupboard together and put wheels under it, so that everything is inside there. All the drugs you need, oxygen is there. Once you move that thing close, you know that nobody's running left and right. So that's another thing. Now, if you have a bed that is soft, either the mattress is too thick or it is too soft, what we do next is, by the side of those crash carts, if you buy the normal one, it has a board that you can slide under the patient, and then you can now use to have a firm surface. If you don't have that, what can you use? Even something like this table you are looking at. If you remove the leg and have this table alone in your ward, you can slide this under the patient, and then, or get marine board, just have a wooden board somewhere. When it's time for CPR, bring it, slide it, a hard board, slide it under the patient, so that you are not pressing it and the patient is going inside the mattress. Do you understand? Patient is going inside the mattress. So don't come and have mattresses that are too thick, too soft, or springed. You will not be able to do what Dr. Olalekan was doing. So again, he said when you are checking, your eyes are on this is where your eyes are. Where is your hand? Carotid. Never check the two at the same time. Hand on the carotid. Where is your head? By the mouth. So head is here, eyes are here, hand is here. Head here, eyes here, hand here. At the same time, you are checking the pulse, you are checking the respiration. And before you do that, you have asked, Mr. Adibambabiekun, that's why it's not good to have a long name. Mr. Fred. Mr. Fred. He's not answering you. Then, again, where's your head? That's your ear to the mouth to listen for breathing. Eyes on the tummy, chest to tummy, hands, fingers here. Just to the left of the trachea. So if you have somebody that's agreeable by your side, take your finger and try and feel the carotid. If you can do that now, so far the person has finished eating. Please don't touch two carotids at the same time. So try and feel it. You should be able to feel it. Please try it, test it. You don't know CPR until you have tested it. Even if you knew before, do it again. I have taught my children how to do CPR. God forbid, my 12-year-old son can do CPR. Do you understand? Teach everybody, teach your nurses, teach your cleaners, your security men. You may be the only doctor in the clinic. Somebody should be able to resuscitate you. Okay. I hope that was clear, Abi. We got this part up to this point. Shout for help. It's not useless help. The help is coming with this. The help is coming with more knowledge. The help is calling for more help. Calling for anesthesia, calling for cardiologists, calling other people, calling an ambulance. Then they have come. Then you start all of that. You are checking how we did, and then compression. We say when you are doing the compression, put a hard surface under or move the patient to the ground if you don't have that. But patient on the ground is not feasible in a hospital environment. So you need to have something by your side somewhere that you can slide. This can happen anywhere. It can happen in your dental practice. It can happen during CS. It can happen in your labor room. It can happen everywhere. So don't think it's cardiology people. No. And patients, waiting area. Even in the waiting area, yes. And patients come back. There are patients walking around today that we have done CPR for. They are walking around. They are fine. In fact, they have done other things. They've married. Some of them are giving birth to extra children. Yes, they are fine. That is because they had the cardiac arrest at the right place with people that knew exactly what to do. Each of these things we have told you increases the chances of ROSC, return of spontaneous circulation, significantly. If you are doing 60 to 80 compressions, the chances are quite low. If you are doing 80 to 100, the chances are better but not the best. If you are doing 100 to 120 to even 140, the chances are much better. And the studies show that from 140 going down, from 130 going down, the chances of return also start reducing. So the switch point is between 100 to 120. Okay, so we just continue from there.
And talking about high quality chest compression, you want minimal interruption as much as possible. And you continue to do that until there's help. So until there is help so that someone can start ventilation. So let's see. So we talk about safety, call responsiveness, call for help. So that's all. We're looking at the chest and the abdominal wall for chest movement. Check for the pulsation. So you can see with the side of the face is trying to feel for the breathing and not spending more than 10 seconds doing that. So look at the picture, straight and the pressure coming from the shoulder. And like I said, minimal interruption, and you want to do that rate 100 to 120, and by the time you have someone to help with the ventilation, you want to do 30 of the chest compression and 2 of the ventilation. So the next question is, how do you place the ambu bag? So we talk about C and E maneuver. So C, that is your thumb and the index finger, and the 3 other finger making the E. So with your thumb and the index finger, that to apply the ambu bag to cover the nose and the mouth with no air escaping by the side. Then the 3 other finger is to extend the neck. So extend the neck. So with that movement, you'll be able to firmly attach the mask to the face of the patient. So nose and mouth fully covered, and the other 3 finger extending the neck. And like I said, 30 compression, and you apply the vent. So you don't need to squeeze the whole bag. So just press a portion of the bag, 1, 2, and the CPR starts again. 30 compression, then 2. And if you're doing it well, you expect the chest of the patient to move. So that's a sign that you've done it well. That means the nose and the mouth fully covered and the neck extended. Previously, they used to talk about doing a swipe. That is no longer encouraged. Extend the neck and fix your bag very well.
Again, C first, put the C first and place it across the face. So use it to press firmly across the mouth and the nose. Then E against the lower jaw to pull the neck back. Press firm first, then you pull the neck back while this is still firm. Don't, if you pull the neck back before you try and press, it will be like you are pressing like this while you are pulling. So you press firm first, then you pull back. So while it is still firm, no space for air to come out from all the sides. Okay? So firm first while it's still back. Now, one thing you have noticed, as you have done this, what have you done? You have occluded any form of oxygen coming to that patient while they are doing CPR. This is one of the major mistakes people make while doing CPR. They put the thing over the person's face. The person is already struggling to breathe. You now carry something and cover his face, and then he can't breathe again. Okay? One relative say, if now you they cover your mouth, you go feel breathe. So what you must do, if you look at all ambu bags, they all have this at the back. If you look carefully, you can see this here. And you should have the supply in that crash cart of the oxygen connector that connects from here to your oxygen tank. So from here to your oxygen tank or to your oxygen supply. In cardio care, we have the oxygen in the wall. So you will connect here and connect to the tab, so that you will have this bag filled up with oxygen. So that any air that is coming in and out, the patient is breathing 100% oxygen. Do we understand? So you must connect this back of this ambu bag to that oxygen before you now start doing what you are doing. Are we clear? How many people have been doing that before? Hi, 2 people. Jesus Christ. Okay, fine. That's why we are here. We are now going to be ACS graduates. Okay, so we connect the back of this to the oxygen something. When I trained, once you move the crash cart near the patient, because the patient is looking somehow, you move the crash cart, the patient's relatives will start crying because they know what it means. But now we know that CPR works and that you can put all of these things together. Connect this to the oxygen, then C first. Can you see the C going first, on the mouth is firm, no air coming out. Then take the E and pull back. Now, if you have more than one person available, which you should have in the hospital, I recommend that one person should do the ambu bag, another person should take the neck. So, one person holding the ambu bag, another person should just come to the head of the bed. Take your double C on both sides and your double E on both ends, and you pull back. Just get a stool. This person should sit down like this. Do we understand? This person's work is just to hold. So if you have taught your team, like we've done around, our cleaners, our security men will just know where to move to. Bang, one person will hold like this, and that person will sit down. That is work for that day. And that person is just pressing, waiting for intubation. Then the other people are taking turns doing the compression, because you will get tired. If you do it for 1 hour, you will get tired. Somebody say, yes, you must give your patient a chance to make it. You must. There's times we will sit down, we'll say, this patient, you must not die. You cannot die. Yes, we will do it until you wake up. You must wake up. Yes. And sometimes they wake up. So one person is here, these other people, once you are tired, change. Another person, change. Another person, change. Before you know it, you intubate. Then you connect, and your ACLS starts. Connect your ECG to the monitors. We will learn that one tomorrow. So ACLS, critical. We will learn that tomorrow, what to do after this basic one. Okay?
So you are doing 30 of this. After 30, ventilation, 2. 30, 2. And as we're doing that, the person bringing the AED, automated external defibrillator, is around. So what will you do? Place the pad. So it comes with 2 pads. So one will be under the right clavicle. Please, the slide. And the second goes under the left breast, close to the axillary region. So that's the picture of the ambu bag. So we can see the C and the E. So if you have to more hands, so one person can hold the mask while the other is doing the ventilation. So the AED is here now. So like I said, to apply the pad, we can see the positioning of the pads. So, and that means if the patient has his clothes on, you have to remove it. If the patient is inside water, so that all of you will not be electrocuted, you have to place the patient appropriately, wipe the water off. If they are here, because some of these pads are reusable, but you don't have time to shave if there is time for that, but you don't have time. So place the defibrillator, and it is so easy to use. Put it on, and you will hear the prompts.
There's no battery in this one.
Sorry, there's no battery. So you put it on. After putting it on, it's going to give you the prompts. And while you are doing this, the aim is not to stop your chest compression. It's not a person doing the compression that is doing all these attachments.
Now. Remove clothing from chest.
So it's just about following the prompts. Most of them will give you direction on what to do. This is a Medtronic type, and there are so many in the market.
Pull red handle to open bag.
Okay, so this each
plastic.
So this is a basic one. It's meant for bystanders, people that don't, including us in the hospital. So if you don't know what to do, just follow the prompt.
Remove clothing from chest.
It will keep on telling you what to do. Next, next, next. While it's doing all of these things, please don't stop CPR. Continue your CPR. As soon as you come,
Handle to open bag.
they've already put it.
Each pad off blue.
So that is exactly what happens. You follow it, it will now tell you whether it is a shockable rhythm or it is not a shockable rhythm. If it's a shockable rhythm, it will tell you, remove your hands from the patient. Now press shock, pram. It will tell you to continue CPR. You continue. After another 2 minutes, it will tell you it wants to analyze again. You remove your hand, it will analyze. So that it's doing the work of everybody together. So this is a 100% needed in every facility treating every patient. If you cannot even read the ECG, you must have this around you, even if it's your church meeting. In this meeting now, we have this one. God forbid we need it. Okay, fine.
So the only time you are allowed to stop chest compression is when the automated defibrillator is analyzing the rhythm and when it wants to apply a shock. That is the only time you are allowed to stop compression. So minimal interruption in chest compression as much as possible. So 30 to when it's time to analyze the machine will give you a prompt. Analyze rhythm, stop CPR, and you will stop. Then immediately it will tell you shockable rhythm, press the red button. So you tell everybody to stay clear, you press the red button and the shock is applied, and the machine will tell you immediately, resume CPR. And if it is a non-shockable rhythm, it will tell you non-shockable rhythm, resume chest compression. And we continue to do that. Next 2 minutes, it will analyze again. Because the mistake we made is the fact that the first one is a shockable rhythm. It's not a shockable rhythm, does not mean it will permanently remain as a non-shockable rhythm. Patients can go from shockable rhythm to non-shockable rhythm, can go back, forth from tachycardia to bradycardia. When we get to advanced cardiac life support, we will know about that. And you continue to do that until maybe ambulance comes to take the patient to the hospital, advanced life team comes, or when all of you are very tired.
Yes. Or when the scene becomes unsafe. Patient relatives are now threatening to kill you. You just find a window to just so that's an indication for stopping CPR. All right. So if it's a child, you put one in front and one at the back. So the surface area is very small. In some at the live ones that we have in the hospital, we have a voltage attenuator that connects here to reduce the voltage for a child. Okay, well that's mainly in the children's hospital. So, but for other ones, if you cannot have that one, put the normal adult one. For a pregnant woman, same thing.
It's the same thing.
For everybody, these same two these things. Okay, fine. What else do I want to say now? So now, if you have the advanced machine, I think we have one old one right there at the back. If you have the advanced one, which is a manual and AED combined, I think we have maybe 4 or 5 in the hospital. What do we do if the patient is having bradycardia, which we will talk about tomorrow in the ACLS algorithm? The patient now is having heart rate 30, 25, and you are doing, what do? You're giving a tropine, patient is not responding. In those advanced ones, you will take the same pads, put one in front, one at the back, and then turn the dial to pacer, and then press it to start pacing the heart. So it will start pacing the heart while you transport the patient to a cath lab like cardio care. We can now put a pacemaker in or a temporary pacemaker in. So in the meantime, you have transcutaneous pacing. Everybody can do this if they have the right equipment. You put one in front, one at the back. You press it to pacer and press it to start pacing. It will send a shock between the front and the back and give the heart a beat. And then you can now move the patient till you get there. It's a little bit painful, so the patient will be feeling small shocks. But at least you move to a cath lab that we can now put in a full pacemaker or a temporary pacemaker, then the patient can be safe. Okay, so that is how to use this. But the large part, if you don't have that one or you don't know how to use that one, make sure you have one of these in your facility at every point in time. They have called me in labor rooms. They have called me in skincare clinics where they were doing Botox or whatever, different things. Pram, if something happened, they didn't know what to do. To compression is critical. The quality of compression is critical, and the time to defibrillation is extremely critical, because the voltage that you will need to stop that cycle, you need a higher voltage with every passing minute. So every passing 10 seconds, you need a higher voltage. At the early stages, a small voltage will pick the heart back. But towards later stages, you will need a lot to be able to pick that heart back. Okay, I think we are almost done.
So I think it's just to do a practical demonstration. That is all what
Show the slides.
BLS is about. So let's just move through this slide.
Okay, everyone should clear while it is shock. Ensure that everyone is cleared. Cycle, let's just make sure we've not done. Before shocking, make sure no one is touching the patient. Follow the protocols. Sometimes put off oxygen. If you see on oxygen flow, you want to put off, especially if oxygen is flowing openly from a bag like that, and it's just open in the air, you want to switch that off. Okay, and using alcohol to wipe the patient's chest, you must make sure that it is dry so that the alcohol does not catch fire with the shock. Okay, so while it's being analyzed, do not touch the patient. Then, in the absence of pediatric pads, just use the normal pad, like I've said earlier. In respiratory arrest, I think we discussed that.
Yes.
There's a difference between respiratory arrest and cardiac arrest. What's the difference? Is anybody here?
There's a pulse.
One has pulse, one does not have pulse, okay? So in respiratory arrest, you can feel the pulse, you can see your ECG running, you give only rescue breaths once every 5 to 6 seconds, okay? You stop CPR once the patient has started moving, breathing, once the AED is analyzing rhythm, when other people come to take over, or when you are presented with a valid DNR order. So occasionally we have patients that have a DNR. They've had a very massive stroke, they have a terrible cancer. The family tells you, please don't wake the person up. Okay? Even my father-in-law told me, please. We woke him up 2-3 times. He said, what is this problem? Allow me to go. You know, so at the next time, we just, because sometimes you can keep on and keep the patient suffering. Then you are alone, or you are too exhausted to continue, or like I said, if you need to run through the window. All right, so can I have the volunteers please come in so that we can, I don't want pediatric ones, keep those pediatric, put it away now, I told you before. We are going to try and be a little bit organized. A lot of people pre-registered, yes, but more than half of us did not pre-register. So we met another half here. So we will still make it work. We will find a way of sharing it first half, then we'll move to the second half, and then we will assist you. Looking at CPR does not mean you know how to do CPR. If you have done BLS before, do it again. Even a 10% improvement in your technique can be dramatic. And like I always tell my doctors, you don't know whether that patient will be related to you. The person that you need to do CPR next, you don't know who it will be. You absolutely don't know. So you must take your time and learn as much as possible. Prof, sir.
Yeah, thank you very much. I think the other thing we need to emphasize is that CPR is a stopgap. Okay, it is a stopgap. You are expecting assistance. So it's to try to keep the patient alive. Okay, but I can see in Nigeria our challenges. I don't know. In Abuja, do you have an emergency number? Can you call an ambulance? Can you call a number that in 5 minutes that somebody is there with an ambulance in 12 hours? Okay, so that's number one. Because the other thing I want us to look at is that let's say it happens on your way to Kefi, and you don't have all these facilities with you. Are you going to do mouth-to-mouth respiration? Because that's very, very important. I think, yes, we have to look at that. So that's one thing. And then the second thing is children. We have to be very careful with children. You might not use 2 hands on a child. If the child is really small, you use your thumb. It's your thumb you use. Otherwise, you will break the ribs of this small child. And the child is gone. All right? So you wouldn't have assisted at all. You would have even caused more problems. Now, why are we worried about CPR? That it must be started on time and effectively. 4 to 5 minutes, brain death has started. 8 to 10 minutes, permanent brain damage. So if you start any CPR, 15 minutes after, you're doing a useless job. Nothing. You know, I've seen people. I've been to a place where a doctor is lying down dead. They called me. It took me about 15 minutes or 20 minutes to get to the doctor, and then I went and met people trying to do CPR. I said, "What are you doing this CPR for? This guy is gone. He's gone. So we must be very. Anyway, as we learn and as we know, okay, what you can do, you know it, all right? So as we perfect our something, we should know that there are limitations. Lastly, what I want to say is, how many of us heard about Sam Okwaraji? Not all of you, the younger ones don't know. When Sam Okwaraji dropped in Surulere, our national stadium that time, what did they do? They went and just cycled and were looking at the way he was struggling to die. Now, I'll take you somewhere again. Patrice Muamba. Who knows about Patrice Muamba? Who plays football? Or who watches football? If you watch football, you will learn cardiology in football. No, the East African. Who dropped, pronounced dead, taken to the ambulance, and 2 weeks later came back and received an ovation. That was in EPL. It's because they have the wherewithal. All right? So, we are not there yet. We can do this in the hospital setup. But how many, I'm sure even in Abuja here, probably the central area, but the periphery, do they have street numbers? Do they have street names? Do they have house numbers? So if you are going to call 911, sorry, is it 122? 122.
How will they find him? He's behind Meshai.
Is it now?
And behind last bus stop. When you reach there, you turn left.
Yes. So lastly, CPR should be taught to everybody. You don't need to have gone to School of Health Technology to understand it. It should be taught to everybody. If you have an organization, insist that CPR should be done. Thank you very much.
Thank you, sir. Okay, people, can we come forward? Dr. Aganya, Dr. Ninowa, please, let's pick one table. Let's pick one table. Dr. Ene. Pamela, where's Pamela? Where's Pamela? Please call Nurse Peter. Call Nurse Peter, call Nurse Monday. Let's come in. We have a procedure. But one of them can come now. Peter can come and leave Monday there. So we'll try and do it. Please don't, if there's not a mannequin to reach you, just hold on. We'll move to your table. In about 15 minutes, 20 minutes, Dr. Abiodun, can you help us with one table? Thank you, sir. Dr. Abiodun was supposed to take cardiovascular pregnancy, but we are running short of time. So we may have to, thank you very much for coming, sir, from your busy schedule. So if it doesn't reach you, don't worry, we'll just be moving till we get to everybody. Please be careful with the mannequins. Dollar is costly now. And everything that you are seeing has been imported for you and for Nigerian patients. All right, so let's put this mannequin in the center and these two tables will come together. Pamela, I need more people. Call cardio care, I need more doctors to come in. more of my team to come in. Dr. Amina, where's Dr. Amina? Chima, oh yeah, come. These two people come. And Dr. Ene, put that on that table so that those two tables can come together. That one is not good. Don't worry, put it there. Then those two tables can come together. These two teams come together. Just turn around to that table. Pamela, I need people. Where are my people? All right. Now we're going to do what we have learned. This is, give me a name that is not common. Mr. Stables. Mr. Stables. We're going to call Mr. Stables. So please, ma, go ahead. All right, so let's practice now. We have been taught now. Oh yeah, oh yeah, you are there. You are my main teacher here. Two of you are here now. So go ahead. Please, go ahead, ma. All right, Dr. Ene, please let's start with them. Dr. Chima, please show them. So you have checked for the patient that is responsive. Oh yeah, tap him now. Mr. Peter. No, not Peter. Mr. Shamfa. No, Shamfa is somebody. Mr. Hay. Okay, Hay. Mr. Hay. You do next. Call for help. Call for help. Help. Oh, yeah. Help. No, you're not teaching. We are practicing. Please, you have to practice here. The next time to be a real patient, and you will be confused. This practicing just makes it into your hands. Okay, shout for help. Help. You have for help. All right. Next, what do? You check for the three ways. You're checking for the breathing and the pulse. So, can you see that? And your eyes are looking at the tummy. Please, okay, just look, just do it. Don't teach. Just put it in your hand. Is your hand on the neck? On one side of the neck. Good. You did not pick anything. So what are you doing next? Compressions. Meanwhile, AED is coming. Okay, so let's start compressions. Put your dominant hand first. If you are left-handed, it means your left hand is coming first. If you are right-handed, your right hand is coming first. So put your dominant hand on the chest, then lock your fingers. You want the heel of your palm to be on that center chest, and then you want it straight. Lock your elbows. Now, if you are too short, like you may not be able to be directly above him, you will end up doing like this. What you need to do is to send for a stool or to press the bed to go down. In the ICU bed, there's a button that rolls CPR. If you just press it, the bed goes flat and goes down. But in normal beds, you may not get it. What you just do is a stool that takes you up. If you do not, you will have back pain and you will not even be successful in the end. Okay? Fine. For me too, exactly, I normally stand on my toes as much as possible and try and bring the patient as close to you as possible, then stand on your toes. And then as soon as they find a stool, I go up. It changes everything. Now, if you also cannot do that one, I've climbed on the bed, even last week. Climb on the bed and I put my knees just as if I'm kneeling down on the bed, and then, you're trying to make the patient come to life. Lock elbows, so you start. 1, 4, 5, 6. You can sit as tongue grip. 9, 10. Yes, please. You are locking your elbows straight. So, anyone that is easy for you, you can make it together or like this. See how she put her hand. So the main thing is this is what you are doing. So if you need this to help you feel spare, it's better. Okay, so that's fine. But me, I normally do like this. Then you want to move that. Remember, the elbow is locked. So we don't want you to do like this. We want you to do like this. Okay. So next, somebody moving. Don't worry, be doing it. We'll be correcting as you are doing. He's not doing exercise. Oh yeah, go ahead. No, you don't start like that. Okay, so you just. No, Mr. Hey, you somebody. Nigerians are superstitious. This table, please come together. You are here now. Oh yeah, start. One move back. See one move back here. All right. We assume that this patient has collapsed. Patient has collapsed. You're on the phone. Ah. Oh yeah, now start. Start. Patient has collapsed. Do it. So don't teach. Just be doing it. So, where's your eye? Your eye is looking at me. No, your neck, your finger is not in the correct place. So, checking by the side, correct, beautiful. You are feeling for the, okay. Now you cannot feel. What do you do next? You start compression. Meanwhile, it's coming. The AED is coming. Your elbows are so calm down. Calm down. Your elbows. Wait. Dominant hand first at the center. It looks easy. Don't worry. When you do your own, you will realize that he's trying. Dominant hand first, the other hand. Are you right-handed? Beautiful. Now you are going to go 1, 2, 4. Good, beautiful. I like how the elbows are locked. Beautiful. Continue. You are doing well. Beautiful. Okay. Continue. You're tired, Abby? Oh yeah, somebody else. Start from the top. If not, you will forget to call for help. Or you will forget to check. Oh yeah. Go on. Make sure they are doing the CPR properly. That you are romancing the chest, though. That chest cannot wake up, oh. It's too soft. Come on. I just telling you how you doing, baby. All right, let's do it properly now. You remember that you are pressing the heart. You are pumping for the heart. Now, I can already see you're going to have a problem. Move the patient closer to you. You may need to stand on your toes so that your shoulder comes on top. Now, if your beds are higher and can go down, you go down. If not, you will get a stool. You stand up and then you hover it. Okay, go ahead. Still too soft. 5 centimeters. Good. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 22, 23, 23, 24, 24, 24, 24. All right. Where's our ambu bag so that we can do the ambu bag while you're doing? Okay, somebody should. Next person, try. Try, and we are correcting you. I need an ambu bag here in the front. I need an ambu bag in the front. Those are the back. We are coming to you, please. Where's the ambu bag that was here? I need to go. You have to do it, looking. Try it. When you have done, you can sit down. But don't assume you know by looking. When we see you, we will laugh. Mr. Paul, how's everything? We are saving lives. This is the real saving of lives. Have we been using this thing at all? You have not been using it. Let me borrow it. Okay, let me try it here. Okay. Fine, take. Okay, so someone can apply. No, you have done the compression, try and apply. You are, see, you are careful. You are putting your hand like this, so don't do your hand like this. So it's just this place. Don't put your hand on both sides of the neck. Okay, so just on one side. Okay. Okay. No, turn that in properly. You are doing comprehension. Don't forget, focus. If you have only one thing you can do and it's only compression you can do, focus on compressions. Compression is the single most important thing you can do, and defibrillation. So the other person is put the ambulance. C first. Put your C first, then your E under the jaw. This man. It's magic. Nope. C, calm down. Where are you? Which hand are you using? Left. On this hand. Yeah. Put your C there. Put the E under the so press this one hard. Is that one pressed? Now pull the other one up while this one is still pressed. Beautiful. Is this pressed? Or you are not pressed? No, you have pressed this back. Don't forget to take it up, this down. Can we see? It's not easy. It looks easy. This is pressing while this is raising. So you are pressing and raising at the same time. Press, raise, and then press. 1, 2. You're pressing too soft. You're pressing 1, 2. You understand? So stop. Now press. 1, 2. And your eyes are here. Because we've not put the nylon very well. 15 to 2. 15. Then 16, 17. Supposed to be green, Abby. Alright, somebody change to the bag. Somebody come to the bag. Please. Any side, doesn't matter. Anywhere, it can be like this, it can be like this. That's why it is rotational. But don't forget to connect your ambu bag to oxygen. The reason this is detachable is that when you have put a tube in, you go to detach this one and connect this one to the tube. But meanwhile, now you are using a bag. This is called a bag valve mask. Ambu bag is the trade name. So this is here. Press down. Press. Always do this first. Now there's no air. Then you now put this one. While still pressing, you now lift it up. If you have other people, somebody should just press like this and stay like this. And somebody else should press. This can be here. This can be here. If you have done, please step back. Another person, come forward. Be moving. Let somebody else come in. Move it to the. Oh, that table has fallen down. You have broken the table. You are breaking tables. We are not doing mouth to mouth. Oh. Yes, there is a mouth to mouth bag mask like this that you can blow that has a filter. It's not this one. Don't worry, somebody will come and fix that table. You are massaging this chest. Oh my God. You're such a nice guy. Oh, all the patient will. Hey, be careful. The table break. The table will not hold you. The table will not hold you. Be careful. This table. Let's. Let him try. He will get it. Okay, so let's move this closer to you. Okay, yeah. Good. So now you have to move the patient closer. Elbows lock. Stand on your toes so that you can be at the front. Good. Now press. We have broken the table. We have scattered this table. This table that we have been protecting in Nigeria since, we have finally scattered it. You are massaging this chest to see you are at 90 degrees. Move the patient closer to you if you can. Stand on directly over your shoulder should be over his chest. Oh yeah, move your shoulder is over the chest. Now stand on your toes and now push. Your elbows pushed. Oh yeah. That's too slow and that's too soft. 1, 2, 3, 4, 5, 6, 7, 8, 9. That's too slow. 10. Don't tire that now. Beautiful. And that person bag, give somebody else to take the bag. You must lend this bag in. Don't take your bag back. Okay. They want to. Okay. That bag thing is not easy. If you don't do it, the patient will be vomiting. There will be a lot of things. So if you don't practice it here, I swear the patient will not wake up. It's not hard. There's no place for that. In a newborn, unlike an adult, the reason is typically ventilation, while an adult reason is normally cardiac. So doing just compression without ventilation is, if you can, in an adult, how is it moving? How is it moving? Something must take it in. So in an adult, it is, if you have only one thing you can do compression. Perfect. In a child, in a newborn, if you have only one thing you can do ventilation. It's the opposite. Yes. So you want to do that one. So if it means you taking 5,000 naira to go and buy it, you go and buy it. It is just the mouth, the smaller. This one, the same. Yeah. It doesn't cost much. I swear it doesn't cost much. You can pay for it. You can pay for it. That is your contribution to humanity. I mean, both are important too, but if the more important ones. So when you now connect that one, I give you and you are ventilating, the child can get air. The child can get air. You can continue your compression, but you cannot do it without it. You can't just put oxygen there. You are wasting time. We have people that are going to go around now. They are going to go back to their hospitals and advise their medical directors as a special envoy from ACS. If anybody saw a car key, we're looking for a car key, but this car is if there's any car key you found that you don't know where it came from, please, I need a drink, I beg. I'm very thirsty. Nana, help you something to drink, I beg. Coke. No, let me raise my blood sugar. Please, I need one ambu bag here. Pamela, let me steal one so that I can use for here. Okay, we should be moving our mannequin to the next place. Your elbows are bending. Elbows straight. Elbows straight. See me using microphone. Elbows straight. Shoulders across. So stand on your toes and lean forward so that your shoulders are directly in front. If you may need a stool sometimes, so move your shoulder forward, madam. Move your shoulder forward. So that exactly, your elbow should still remain straight. Don't bend that elbow. Keep that elbow straight. Lock it now. Push. Now push. 2, 3, 4, 5. That's very soft. Push that in. 1, 2, 3, 4, 5, 6, 7, 8, 9. Faster. Beautiful. If you do a good CPR, your body must pain you. Your body must tell you. Take that ammo back. That's one. Please take this one. Take the mannequin to the back. Let's start at the back. Ogo, take to the back and take one other table. Not that one. That one is too soft, Nabi. Give them that one. Let them use that one and exchange it. If you have practiced, you can sit down so that other people can. The people that are left, we can see. If you have practiced, but if you have not practiced ambu bag, please practice ambu bag. It is very, very difficult to do. I can tell you from experience, it is very difficult to do in the real life setting. If you have a question, just raise your hands. If you have a question, just raise your hand. After this, we'll do a debriefing session. We'll talk about a few things so that you can cement what you have learned. CPR works. It works. I'm sure some of you are seeing things you have not done before. And that is why you think CPR does not work. It works. Dr. Okoli, you've learned some things, Abi. Your next patient will not die. Don't forget to practice calling for help. Aha. That's because your shoulders are not aligned. Your shoulder should see. Move your shoulder forward. Forward. Move your move. Put your hands. Put your right hand. Are you right or hand? Are you left? Okay, good. Now move your shoulder forward before you start. Move your shoulder forward. Correct. You stand on your toes so that you can move forward. Correct. Now push. 2, 3, 4, 5. That's better. That's a lot better. Don't mind the light. You see the light is turning green now. All right. If you have done, you can sit down so that we can now move to the people that have not done. People that have not done, you can come around if we have not gotten to you. Learn it so you don't know who you need it for. Have you done here? Can we move a mannequin to the back here? Pamela, I need a mannequin. Move. Some people are doing over and over again. They are taking extra. Jara, is enough. Don't worry, it's coming.
We are always adding. These charges now that you say it's improved with time. That the more the voltage.
Okay.
I never knew that. Yes. That the higher the voltage. The higher you yes. So anyone is more successful. Yes. And then also depend on the locality of the future.
You have been hiding ammo bags. Hi. Ambu bag. Please, we have one last thing to do before we go. One last thing to do. We are going to take some questions and answer some critical things. Please, those of you here that have not done, can you please move to a table in front? Just move to a table in front since they are doing the resource allocation. Please, let's just move. Please carry anything that is valuable. Move to the front here. Let's join up. Make sure you practice. Don't just look. It's better we laugh at you now. Beautiful. Oh yeah, come to the ambu bag. Bring ambu bag here. Here, take. The people that told them to come forward. Anybody that's not done, please come forward. Come and join a place. If you have done, please sit down so that we can allocate people that have not done. So we have broken some tables. Please help to fix the tables. That's too soft. You are just massaging that chest. Hey, Oga. Romantic. That you are doing it well, actually. But you are too good. Move a little bit faster. That's too slow. Thank you so much. It's not easy, Abi. If you do it properly now, you will know that what you have been doing before was not really a CPR. The last year, somebody came and said the patient woke up. That he thank God they came for ACS. The patient woke up and the patient is alive today. So learn it now. Or you put that bag, put the C first, put the ambu bag, put the C first. Or you put your C first. Don't worry about the bag. Take the mask. Put the C first. Then take your E and pull up. Don't worry about this bag while you are doing that. This your E. You need to use your dominant or your non-dominant hand. So do like that. Put that here. Now put your E under and pull it up. Good. Have you done that? Press it first. Make sure there's no air that will come out. Then press it now. You can now press. Press now. No, you are following the head again. You have to pull it up. If you don't pull the chin up, the air will go to the patient's stomach. The air will rush to the stomach. You'll be pressing thinking that you are doing, but the air will be in the stomach. And then that stomach will get filled with air, and splint the diaphragm and stop the patient from breathing completely. The next thing you will see, and some of you have already seen it, is that the patient will just vomit. You will just see food everywhere. And that is all. You have killed the patient. So that head must be raised up while you are doing your ambu bag. Put your C first, press it, then pull up, so that when you press the bag, the air goes directly into the trachea and into the lungs. If the head is down like this while you are pressing, you are only putting air into the tummy. The tummy will just be growing bigger. Next thing, the tummy will just do pwah, and the person will vomit. All the food will enter the airway and shikena. If you have not done, please come. Practice. Let us correct you now. Practice. Let us correct you now, please. If you have a question, just signify so that we can answer your question. All right, if you are done, you can sit down. If you have not practiced something, you can come and practice. You want to do your CPR 100 to 120 beats per minute. I want to take some questions now. And very, very important announcement against our training for tomorrow. Tomorrow we have basic life support. We have, ECG. Please come on time. ECG, and come late for ECG, you won't know it again. Once you hear the full lecture, you will read ECG. I promise you. If you can read, you will read ECG. So that will happen tomorrow. We also do advanced cardiac life support tomorrow. We also do cardiovascular disease. What else is? Don't throw away your jotters. There are a lot of valuable information. The basic life support is there in your jotters. The algorithm for managing chest pain is there. We're also doing chest pain. It's inside your jotter. The slide for managing when somebody needs a pacemaker is there. A lot of acute ACLS, advanced cardiac life support, is there. So there are a lot of things that you should use. You should keep that jotter close to your heart. You are going to use it over and over and over again. If you join the WhatsApp group, we'll also try and post some of those algorithms so that you can share them to your hospital staff on your WhatsApp group, and they can practice it. The more, the better. Yes, sir. Just go ahead. I can hear you. Okay, the question is, can you do CPR for yourself? That's the question. Before you collapse, can you realize that you are going to collapse and do CPR for yourself? The answer is no. As you have seen, even if for somebody else is hard. If the person is more than 150 kg, you not say you go walk. It's very hard. Okay, so you cannot do CPR for yourself. That is why you must teach everybody around you. Teach your wife, teach your children, teach everybody. My wife knows CPR. Yes. Teach everybody around you. Teach your staff, teach your gatemen, teach your house helps, everybody. We have scattered the table finally. We have scattered this table. This table we have been shaking since in Nigeria. Okay. Yes. Yes. I'm sure he lost. All right. Mouth to mouth CPR in a patient you don't know. Question. Mouth to mouth CPR in a patient you don't know. What do you do? Second question. In a pregnant woman, how do we do this CPR? In a pregnant woman, the tummy is big, 36 weeks. What do we do? Any other question? Okay, can we all sit down? Can we all sit down? Can we all sit down? We'll be rounding up in the next 5 minutes. Let me just explain these last two questions. Thank you, Dr. Atta. Thank you, Dr. Williams. Who else can I see? Dr. Olulode, thank you. Femi, thank you. Dr. Sanke, the real Dr. 90210. Thank you, thank you. Dr. Okopi, thank you. Who else can I see? That's a cardiologist. Thank you. All our team, thank you. All right, I think we can sit down. Let me answer those two questions. Please, count my mannequins, I beg. It costs plenty money. 4 mannequins cost close to 2 million naira. Yes. So you know that the 10,000 naira that we ask you to pay is only to make sure that you are paying attention. It's not to cover anything. Hopefully, that you are paying attention because of the money. All right. If it's a pregnant woman, what do you do? No difference. Pregnant, not pregnant, everything exactly the same. Forget the baby. Continue your full CPR. Give your full compressions. Put the mask as you ought to do. Get your defibrillator. Attach it. Put it on. Shock. Everything normal. No change. Question. It's a lady and I'm a guy. What should we do? Yes, answers. Some people, like, when somebody asked the question, somebody was sued in the US for doing CPR successfully. The person came back to life, but that they did mouth to mouth and that they exposed her or something like that. I think they lost that case. Who remembers that case? I think they lost the case. I'm not sure. Okay? So, in CPR, dignity is not there. There's no dignity in death. Except there is a valid order. Now, what we are teaching you is in-hospital CPR. So I expect that you have all the standard things to close the door, to get unauthorized people outside. Some people are just standing. Even in your hospital, send people away that are doing nothing. They are just looking. Hey, yeah. Huh. See as he's even pressing the chest. Because the next thing is that people will start videotaping you and put on social media. You do not want that. It is unnecessary pressure. So, keeping the place safe means even keeping your psychological strength safe. So you need to ask people to go out that are doing nothing. So make sure you get it under the left breast and under the right clavicle. Then you put it on. Once you have put the pads, you don't need to leave the person exposed. You can still cover the person and continue your CPR. Do you understand? So you don't have to leave the person exposed. There's nothing you are doing there. Once you have put your pads, you can cover the person back and continue. The only thing that must go exclusively is a bra or something like that. And you continue your CPR. Okay? Yes. Is there any other question? Any other question, please? Stranger. For mouth to mouth. Okay, stranger, mouth to mouth. Please do not do mouth to mouth for a stranger. It is not safe. I've seen somebody do mouth to mouth and the patient turned out to be HIV positive. And the patient did not wake up on top of that. Is that not 3-0? Turned out to be HIV positive. He was hiding it. Somebody there knew and the person kept quiet. And the doctor asked, the patient put mouth. Woo, woo. We did. I was looking at him. He wore me. He did. Then when the patient was HIV positive, and the patient did not wake up. So you have just exposed yourself unnecessarily. So please do not. Now there are some special valve masks. This same ambu bag that we used. There are some masks you can buy it. It's a pocket mask. You can order it on Amazon. It's a pocket mask. It has a filter there that you can put in, raise the same way we talked about, and then blow. There's a filter that stops anything from coming back to you. So if you can get that one, you can have that in your car or something that you can put, and then you can blow. So that is one possibility. So apart from that, American Heart Association has brought out the hands-only CPR. Hands-only CPR. That even if you did only compressions very well with defibrillation, you still have a very, very high chance of success, even without ventilation. So that putting mouth, except maybe in the swimming pool or something, the increment is not much, so you don't necessarily have to, make yourself unsafe. Is there any other question? Yes, please. Can somebody go with the mic? Gilna, come now. You don't have to make yourself unsafe. Tomorrow we will learn how to read ECGs, and then we will learn how to combine this to advance cardiac life support. What will you do next? You are doing this, patient is not waking up. There are some things you will start doing. There are some drugs you will start giving. The patient will wake up. The patient will wake up. I have seen patients, they are woken up, they are fine. I secreted one on last week, or this week, on Tuesday. I secreted him. How far, bros? How far? He didn't pay complete money, but at least. All right. Yes, please.
My question is in terms of the medical legal aspects, especially in terms of out of hospital CPR. How do we safeguard ourselves as health workers? Because you might find someone on the road, you want to do all this, and then the person dies. Next thing, the police is holding you as the prime suspect.
Okay, so medical legally, in medicine and medical legal practice, there are components of what is called medical negligence. Number one component, a duty of care must be owed to the patient. If somebody collapses outside, it doesn't concern me. I don't have a duty of care to that person. But if the person is under my care, I have a duty of care. That's one. Two, when you gave that duty of care, you gave it as a bystander and as a doctor, yes. The moment you engage and you do the wrong thing and you cause more harm, yes, you could be liable because you did the wrong thing and what you did may have complicated it. But even then, there is no medical legal complication in that because a duty of care was not owed you in the first place. You did not have to help. You could have walked away. You did not cause their problem. You were only trying to help. right? So you do not have any medical legal implications. Number 3, there is the principle of Good Samaritan. And it is considered almost negligent for you to have the prerequisite skill to save somebody and to walk past the person. It is inhuman for you to have the requisite skill. So do not consider that. It does not have any legal standing because you don't have a duty of care. Number 4, even when a duty of care is there, it must be proven that you did not deliver your duty of care, number 1. You did not deliver your duty of care well, number 2. And because you did not deliver your duty of care, the person died. Nobody can say that somebody has a CPR died because you did not do something well. Because we know worldwide, even in the best of centers with everything available, the whole team plus intubation, success from CPR is still about 10, I think it's 6 to 10%. It's still about 6 to 10%. So that you did or did not do, I mean, the patient had a 80 to 90% chance of not making it. So that cannot be proven in any way, form, or fashion. Okay? Fine. Now, that being said, any responsible medical practitioner in Nigeria, in any locality, needs to have a good relationship with the police around in the area where you are working. That is a basic life support skill. It's a personal life support. It's not for other people. He must have a good working relationship. Go there and do their blood sugar for free. Go and check their blood pressure. Make sure they are around so that nobody can just mess you up unnecessarily. Okay? Yes, is there any other question? Yes, please. We are rounding up.
Please, my question is in terms of management of a diabetic patient outside hospital, what are the things that you can do or the person should avoid?
Okay, so that question is manifold. For us, what we are focusing on is in-hospital management. For at home, the main thing there is diet, nutrition, compliance, and knowledge of hypoglycemia and knowledge of complications. We teach the patient food care. We teach the patient hypoglycemia. We teach the patient about the nature of the disease. We teach the patient about the nature of drugs. We teach the patient about adherence to drugs. And then we teach the patient about diet and lifestyle changes. That's what we teach the patient for diabetes. Having taught that, the patient must go to the hospital. Now, this is ACS 2023. There are a lot of things we have said that does not go hand in hand with poverty. Hello? There are a lot of things we have said that does not go hand in hand with poverty. There is a level of medicine you cannot practice without an ECG. You cannot manage a hypertensive and you've never done an ECG for that person. It is quackery. You cannot call it a hospital and there is no ECG there. There is no ambu bag there. It is quackery. Okay? So, we're not talking about that. We are not talking about that. If you have to practice well. Glucometer, you must have a glucometer. You must have an ambu bag. And if you call yourself a hospital, you must also have an AED. It's not costly. Even if you apply for people to grant, to donate to you, it will be there. But the one patient it will save out of 1,000 is worth it. And God forbid, that patient could be you. When I was in training as a resident, I wrote to the CMD of my hospital that I cannot work in a ward where there is no AED or this thing. They sent somebody to warn me. And that there is no thrombolytic in the hospital. You will not believe it. Within 2 months, one of our professors had an MI. And there was nothing to resuscitate him. There was only one defibrillator, a monophasic, in the entire 1,000-bed hospital. And all of us residents went to go and wait in Iwo Road Park, waiting for a drug to come from Lagos. Can you see that what you may be talking about may be you are saving? So make the effort. Our government is not broke. Our patients are not broke. They have enough money to sue you. And you are not broke. You can take 10,000, 20,000 and buy an ambu bag. You can make sure that anytime you are doing a surgery that there is an AED around. There is a monitor that you can look at the ECG. When you are operating, things are feeling one kind. You can look up and notice something. even if your anesthetist is not noticing it, you can say, that is this rhythm, you should have started ACLS. Not that everybody puts on. So there are some things that are incompatible. You will not be able to make a proper diagnosis of an MI, of a heart attack, without troponin. So either you have it, or you have a relationship with a center around you that has it, or you have a relationship with somebody that has the knowledge that you can ask a question. But to try and do certain things without certain things, not possible. No, I never know. Maybe you never know. This is not standard practice. So let us teach standard practice. We've taught you some ways you can manage around this. I told you how to do a crash cart. We have that one before we could make it better. Before we bought the standard one, I called my carpenter. I said, bros, see this picture now? You can make it now. He made it out of the wood, put it, and we put wheels. And we had a place for oxygen. So when you put it and drip stand, when you move it, drip can be going, emergency drugs are there. You can manage. I've showed you how to use just normal wood, like this wood on top. Keep it there and use as a backboard. So you can manage some things. Some other things you cannot manage. AED, you cannot manage. All right. There's a QR code for feedback on your table. Please, can you please scan it and just give us some feedback? Let's know what we can improve. Let's know the lessons, any lectures you want to have next year. Please just scan it. Yeah, that's for referral. There's one for feedback. Just check. Check. Mr. Nakela, the QR code for feedback, where is it? There's one for feedback. There's feedback here, Abby. Okay, so can somebody just help? Jude, pick this QR code for feedback. Take it around. If there's QR code for feedback, please just wave so that we can. That guy that is carrying, you are not listening. Look for the one for feedback. Feedback. Bring it closer at hand. Give the red and just scan. Tomorrow, please, 8 to 8:30. Let's be here. Please, when you are snapping your pictures, tag hashtag ACS 2023, hashtag cardiocare, so that we can pick up your pictures and we can put them all very nicely. I'm sure you've had value for your time. Tomorrow will be mind-blowing. ECG, ACLS, what again? MI, heart attack, and interventional cardiology. We are going to show you a sneak peek into our cath lab. Some of our team have had to leave me behind here. I think we are doing 2 angios this evening. They have started, they have completed the first one. I'm putting a stent, and the second one we'll do this evening. If you have time and you are around, why don't you can just pop into cardiocare whenever. And then hopefully sometime during the year, we'll announce an ECG master class where I'll just take about 20 people and sit down with them and we do the thing to the end. But apart from that, if you come tomorrow, everybody that can read will read an ECG. I don't care what has happened to you before. Just wipe away all your bad memories. It will come with a fresh mind, clean slate, and be sure that everybody, stammerer go last, call the papa name. All right, thank you very much.